Retinopathy of prematurity is a leading cause of blindness in babies and neonates. As its name suggests, it's more common in premature babies. It's more common in low/middle income countries, not middle income and not low income. Low middle income countries, and we'll talk about why this is in a bit. But first let's talk about the pathophysiology of this disease. This disease is broken down into two stages. The first is a state of hypoxia. As you know, in premature babies, their lungs aren't fully developed yet. So they can't breathe as efficiently as normal babies can, and so they don't get as much oxygen as they're supposed to. This is treated by giving them additional oxygen and so on and so forth. However, if you give them too much oxygen, which often happens, you also run the risk of causing hypovascularization, low vascular growth. Normally, vascularization occurs when the body detects that parts of it aren't being as oxygenated as they should be. So the body grows more blood vessels in order to bring more blood, more oxygen to that area. However, if you're getting artificial oxygen, you don't have this vascular growth. The retina thinks that it's getting enough oxygen naturally, so it doesn't grow as many blood vessels as it should. Stage 2 occurs after you're weaned off the oxygen, and suddenly your retina's oxygen saturation levels drop. That's when you get a state of neovascularization, compensatory hypervascularization in response to low oxygen levels. This causes high levels of VEGF and IGF-1. These are two hormones that increase vascularization. To sum it up, stage 1, characterized by hypoxia, baby is often given supplementary oxygen causing hypovascularization. Stage 2 is when the baby's off the oxygen and you get a state of mild hypoxia again, leading to compensatory neovascularization. This also explains why it's more common in low and middle income countries. In very low income countries, babies born prematurely often don't get the oxygen at all, unfortunately. You don't get that state of hypovascularization. However, in middle income and obviously high income countries, you do get oxygen therapy, but you also get regular screening for retinopathy of prematurity. Low middle income countries are kind of in the middle, and so they get sort of the worst of both worlds. Unlike low income countries, premature babies often do get supplemental oxygen, but unlike middle income countries, retinopathy of prematurity screening is more rare. So retinopathy of prematurity comes up more often. Let's talk about the risk factors of ROP. As the name suggests, the biggest risk factor is prematurity of the baby. If a baby is born premature, they are more likely to undergo hypoxia and hypercarbia, leading to hypovascularization and therefore have a higher likelihood of getting the disease. Risk factors associated with prematurity are obviously associated with ROP as well. These include teenage pregnancies, suboptimal prenatal care, low socioeconomic status, and so on and so forth. Because of how common this is, it's very important to screen babies for ROP early on so you can go and treat it. So, which babies do you screen? Premature baby is under 37 weeks AOG, so you obviously screen those. If the baby is born before 32 weeks AOG, if they are born under 28 weeks of age of gestation, then you screen them when they would have been 31 weeks AOG. So, if a baby is born at 28 weeks, then you screen them 3 weeks later when they would have been 31 weeks AOG had they not been born prematurely. If they were born between 28 and 32 weeks age of gestation, then they are screened at 20 days old, regardless of how many weeks old they are. You also screen all babies who are born under 1,500 grams, and you also screen babies born between 32 and 36 weeks AOG with what I call STOIC risk factors. STOIC is a mnemonic, and it stands for babies who have undergone sepsis, who have undergone transfusions, who have required supplemental oxygen, and who have had instability in their clinical course. So STOIC, S-T-O-I-C. Screening is done via fundoscopy, basically using an ophthalmoscope to look at the fundus at the back of the eye. There are a few ways to classify retinopathy of prematurity, and we'll go through them here. The first is by dividing the retina into 3 zones. Zone 1 is this zone here around the center of the eye. It has a rather specific definition. Namely, it's a circle around the optic disc. I've drawn that in purple here. And the radius of the circle is equivalent to twice the distance from the optic disc to the macula. The macula is in black. Zone 2 is everything outside Zone 1 up to the nasal oris serrata. If you remember from the posterior segment lecture, the oris serrata is that structure on the outside rim of the retina. In Zone 3, it is the rest of the eye that's not in Zone 1 or Zone 2. Because of the way the numbers go, 1, 2, and 3, you may think that the higher the number, the more severe the disease, but it's actually the other way around. The closer the retinopathy of prematurity is to the optic disc over here, in other words, the lower the number, the closer it is to zone 1, the more severe the disease. Two other things you gotta know are plus disease and aggressive posterior ROP. Plus disease is just basically retinopathy of prematurity, except the blood vessels look tortuous. That's the word used to describe them, tortuous. As opposed to normal retinal blood vessels, which look rather straight. These are very curvy, very kinked. They look a bit corkscrewed. The other disease, aggressive posterior ROP, is just ROP, but with a more severe clinical course. It progresses faster and it's more damaging. The other way to classify ROP is via vascularity, specifically how the blood vessels grow on the retina. Stage 1 ROP is characterized by the presence of a very thin demarcation line between the normal retina and the zone where ROP has occurred. As you can see, I've drawn that here. This up here is the neovascularized retina. This down here is the normal retina. You'll see a small demarcation line, a pale demarcation line, but it's not as thick as the next stage. Stage 2 is where you get an actual ridge between diseased retina and normal retina, and that's what I've drawn here. The ridge will look rather elevated as opposed to the flat line that characterizes stage 1. You have this hypervascular retina up here, you have the normal retina down here, and then you have a rather thick ridge in between the two. Stage 3 is where you get extra retinal neovascularization, in other words, neovascularization that reaches outside of the retina. I've drawn that here. As opposed to stage 1 and stage 2, where the changes happen within the retina, stage 3 is when blood vessels reach outside the retina and start entering the vitreous humor, that big jelly-like substance in the middle of the eye. That's what I've drawn here. Lastly, stage 4 and stage 5 is where you get some detachment of the retina. Stage 4 is subtotal detachment. Some parts of the retina are detached, but not all of them. You divide stage 4 into two stages, 4A and 4B. 4A is where the macula is not involved. Other parts of the retina may be detached, but the macula is still attached to lower layers. In stage 4B, some of the retina is still attached, but the macula is already detached. It's not total retinal detachment because that's stage 5. Let's talk about treatment options for retinopathy of prematurity. Any stage 4 or 5 retinopathy of prematurity has to be treated with retinal detachment surgery. If you see this, automatically do surgery. You can also use anti-VEGF medication. If you remember, VEGF is a growth factor that causes neovascularization. Some people think that if you administer these medications, then you can cause less neovascularization and limit the impact of the disease. This is still in the experimental phase. We don't know yet whether we should recommend it or not. If it's not stage 4 or 5, treatment depends on whether you have type 1 or type 2 ROP, and we'll go through them here. I've listed the criteria for classifying ROP as type 1 or type 2 over here. Type 1 ROP gets laser ablation. You can have type 1 ROP if you meet any of these criteria. If you have a ROP that reaches zone 1, it doesn't matter whether you have involvement of zone 2 or zone 3, as long as you have zone 1. That's at any stage, but with plus disease, then you automatically get laser ablation. If you have zone 1 ROP, that's at least stage 3, but without plus disease, you're also type 1 and you also get laser ablation. If you have a ROP that's limited to zones 2 or 3, but does not reach up to zone 1, and is at stage 2 to 3, and has plus disease, then you are also type 1 and you get laser ablation as well. All other scenarios are type 2, or as I've mentioned before, if you're at stage 4 and 5, they get retinal detachment surgery.